co-chairman, moderator, organizer, audience. First of all, let me make some correction. I am not associated with Rashilti Medical College anymore. I'm an independent. के तौर पे आ रहा हूँ. अभी recently, but in a very good environment, I just said we had enough. Very cordial relationship still I enjoy. So I was requested to talk on this very common, little unromantic topic, CBC. We often see this report. But I understand if you examine it carefully, it has got wealth of information. Now compare these two. This is, on one hand, you have this computer printed. This one is okay. On one hand, you have very unflattering, unimpressive, computer-generated CBC report. Most laboratories will reprint on the proper paper, but the original report comes from the machine like this one, and in many public sector hospital, this one is given to the patient. Oh. It's just like a very unimpressive invoice you get from the grocery store. What is this CBC? It's a computer-generated slip by auto-analyzers. These days, everything is getting automated. That makes the machine very efficient and very reliable actually, because humans are many times source of error. So machine is very accurate when it comes to counting, measuring. I think it's very important, and it should be interpreted along with the history. It gives very important clues to the various hematological disorders. History, of course, is important. So by the time you look at this CBC report, you should have something in your mind already. That patient is likely to have blood deficiency because of iron deficiency, something like that. So this is a terminology. CBC refers to, so RBC is the red blood cell count, which is like 5.5 million in men and 5 or slightly less in women. HB is measured in grams. It's like chemical test. Hematocrit is total packed cell volume. And these are directly measured by the machine, the counter, the auto-analyzer. But there's a built-in computer in this machine, and which calculates many values like this one. I will actually avoid details because these presentations are primarily meant for postgraduate students, emerging physicians, so I go into the detail for their better understanding. But here I would like to be more practical. So these are very easily derived from this. How do they do this? I will not go in the math involved, but these values can be calculated, and when you see the report, you will have already there. Mean corpuscular volume. That refers to the volume of an individual cell. Mean corpuscular hemoglobin, that refers to the average amount of hemoglobin in one red blood cell. Mean corpuscular hemoglobin concentration refers to the concentration of hemoglobin within one cell. It is actually possible to have two cells of different sizes to have same hemoglobin, but if one is bigger than the other one, that would have probably less concentration. And I'll show you an example also. And very important parameter is RDW, that is the red cell distribution width. It is not the width of an individual cell, it's a measure of the variation of the cells. For example, there may be two examples. In one case, all cells are uniformly small, and in another example, cells are small, but there is a lot of difference in the cell sizes. In that case, RDW will be different. So in a practical situation, this will help you to differentiate between two important clinical conditions. So these are derived values. So again, some nomenclature. This is a hand-drawn normal RBC. Imagine this is the normal size, which is about 7 micron. It is called Normocytes. So if you have the morphology consisting of these type of cells, it will be called Normocytic. Then on the left you have microcyte. It's very easy to understand. It's smaller than this cell. It's microcyte. And if most of the cells are present like this, it will be called macrocytic picture. Then we have macrocyte. On the other side, the bigger cell, so that will be called macrocytic. So there will be mixed picture also. Now, another nomenclature, this is the color, actually the amount of hemoglobin in individual cell. Chrome is color. So the more hemoglobin, the more red the cell will appear. So this is normochromic, but this cell you can see is quite pale. So this would be referred to as hypochromic. Hypochromic means it has got less hemoglobin and it looks pale. Then there is no actually hyperchromic because, well, in spherocytosis you could have macrocytic picture, but when it comes to anemia, we don't use this word hyperchromia. So this cell is bigger, but is pale. So if you measure their mean corpuscular hemoglobin, they might have the same. In fact, this might have more, but it has got less concentration, and that will be reflected by another measure called mean corpuscular hemoglobin concentration. So we refer to the size as macrocytic, microcytic, normocytic. We refer to the amount of hemoglobin as normochromic or hypochromic. Then we refer to the concentration as mean corpuscular hemoglobin concentration. And then another term which is used in CBC is RDW. Now this is an example. These are two populations of cells. Both are microcytic. And in this case, the variation within the cell is less. So the width of this graph is narrow. So it will be narrow distribution. But here, the average cell size is same, microcytic picture, but the variation within the cells is more. So although it is broader, so this would have increased RDW. Both may be microcytic of the same degree, but this would have greater RDW. Now this is relevant to hypochromic microcytic anemia. Both have hypochromic microcytic picture, this iron deficiency and thalassemia. But in thalassemia, all cells are uniformly small and uniformly contain less hemoglobin. Because वो जिस सांचे में बने वही छोटा उस पेशेंट का hemoglobin है. So RDW, increased RDW will indicate presence of iron deficiency. So that brings me to this. ये automatically क्यों advance हो रहा है? आप कर रहे हो? Okay. So this is my favorite topic, a 3-step approach to the diagnosis of anemia based on CBC. So this is the example of CBC. The first step is to look at hemoglobin. There are actually 3 panels. This panel, this one is RBCs, which is I will be talking about mostly. This is WBC, and this will also be relevant in some cases, and this is platelets. So we will be concentrating on this. First step is to see hemoglobin or hematocrit. Of course, you need to have low hemoglobin and low hematocrit first to diagnose anemia. And second, we go to this panel and we decide the morphology. This MCV, on the basis of this, we'll see if patient has got microcytic or normocytic or macrocytic. On the basis of MCH, we will decide if it is normochromic or hypochromic, and then MCH will further guide us. And the third step, RDW, will tell us which of the 2 hypochromic microcytic anemia this patient might have. Commonest anemia in our population is hypochromic microcytic. So I will be spending more time there. So these 3 steps, if you go through methodically, and I think majority you will be able to come up with a proper diagnosis. In some cases, of course, in other hematological disorders, this would be important, and this would be important in like thrombocytopenia, thrombocytosis, this would be important. In leukemias and aplastic anemia, this would also be important. But I'm going to restrict myself here. Now this is a little practice session. I like your engagement. So this is the CBC report. This is the patient report, and this I have inserted the normal. Although a good physician, even a good house physician, would remember these values because these are so often referred to. We normally remember the common reports. So, but you can tell there's a first step. This is normal range, 12 to 18, and hematocrit 37 to 52. Normally, the ratio of hemoglobin and hematocrit is 3 times. I don't know, is this some virus or what? Somebody is sliding, advancing my slide. So first step, HB, hematocrit. In this case, it is what? Low. HB is low, hematocrit is low. So one thing we are sure that this patient has got anemia. As a second step, we'll see this one. MCV is low, so this patient's got microcytosis. MCH is also low, so it has got hypochromia. I think at this moment we can just ignore this MCHC. So I think we have made a diagnosis of which anemia? We have made a diagnosis of anemia here, microcytic, hypochromic. So I think very simple, logical, hypochromic microcytic anemia. You are now much closer to the actual diagnosis. First step anemia, second step hypochromic microcytic. Now there are fewer possibilities. To start with, there are a number of possibilities. After figuring out this morphology, we know it is hypochromic microcytic. So commonest cause in this situation would be iron deficiency. In fact, I always say if you cannot determine the cause, consider it iron deficiency, at least in our population. So if that is the case, history would lead you, for example, somebody having menorrhagia, somebody having bleeding piles, somebody having acid peptic disease, history would be already suggesting the possibility of iron deficiency, but after looking at this morphology, you will be sure that this is actually iron deficiency anemia. Physical examination will also guide you, but mostly the examination finding the same in all anemias. There is one specific finding of iron deficiency, that is koilonychia. Iron studies may be needed in some cases, not in majority. I think in majority they are not needed. If there is iron deficiency, iron deficiency is more likely to be due to chronic blood loss rather than nutritional deficiency. Although in our country, nutritional deficiency is also possible. Both can also exist. So if somebody has no nutritional deficiency, apparently the food intake is okay, and there is no blood loss, then you will have to search for occult blood loss, because this could indicate a serious GIT disorder, especially in elderly. Now, if you have ruled out this by history or by appropriate lab, only then you would consider thalassemia as another cause of microcytic hypochromic anemia. Thalassemia is not rare, but much less common than iron deficiency. First you consider iron deficiency and do appropriate tests, take history, correlate the history. If that is not the case, then consider thalassemia. Of course, in some cases, because of the family history of thalassemia, we straight away consider thalassemia also. In thalassemia, again, history is important, family history, and if nothing to suggest iron deficiency, I think thalassemia would become a diagnosis. Then we come to RDW. Although for thalassemia, you might consider that you will have to do the iron studies and the thalassemia test, which is electrophoresis. But if you examine CBC carefully, just CBC, 90 rupees test, RDW is increased. It should be less than 12, it is increased. What does that tell us? That tells us that although cells are microcytic, hypochromic, but the variation is more than normal, because iron deficiency develops over time. So maybe at different times, cells were made with a different level of iron deficiency and different levels of hypochromia and microcytosis. Whereas in thalassemia, all cells are made the same way, all are uniformly microcytic and hypochromous. So with this little test, you could tell that this is not actually iron deficiency type, it is more likely to be thalassemia. So if you want to do tests for iron study, you have to do the serum iron, TIBC, transferrin saturation, ferritin. I could talk about all of them 2-3 minutes because all have merits and demerits, but I'll skip that, the detail. You normally do all of them to make a sense whether there is iron deficiency or not. If there is no iron deficiency, then we consider electrophoresis, and I was requested by Chima Saab that I include some slides for electrophoresis because iron deficiency, after iron deficiency ruled out, then we go for thalassemia. So I'm going to talk about electrophoresis very, very briefly. So I think that takes us to normal hemoglobin molecule. You know, this is normal hemoglobin molecule. Hemoglobin A is our main hemoglobin. In adults, there are 3 normal hemoglobin. In adults, most of the hemoglobin is A, which consists of 2 A chains and 2 B chains, beta chains. We have 4 chains, 2 alpha chains, 2 beta chains, that constitute about 95 to 98%. You can see 2 alpha chains and 2 beta chains, plus there is heme, everything we can ignore. So this is hemoglobin A. Then we have hemoglobin F, which is predominant hemoglobin in fetus, but in adults also up to 2% there is hemoglobin F, which is 2 alpha chain and 2 gamma chain. This is normal hemoglobin. It works as normal hemoglobin, though it can be identified. It can be identified separate than A by electrophoresis. Then we have hemoglobin A2, which has got 2 alpha and 2 delta. Up to 3% we can have this one. This is hemoglobin A2, 2 alpha, sorry, this one, hemoglobin, fetal hemoglobin, 2 alpha, 2 gamma, and this is A2, 2 delta, and 2 alpha. So if you see this one, all 3 hemoglobins which are present in adults, I'm mostly talking about the adults, all have alpha chain. Alpha chain is indispensable. You cannot imagine a functional hemoglobin without alpha chain. Whereas beta chains is not indispensable. Beta chain can be replaced by gamma or delta. They will still be hemoglobin. They will still be functioning hemoglobin, and we can identify these if they are more in concentration. So in any condition, if beta thalassemia, and say for example beta thalassemia, if beta chain is not made in sufficient quantity, these alternate chains will be made, and that will detect the test. This is the whole theory. Further explanation, this is alpha chain. I'm going to talk about the normal alpha chain, and then other 3 chains would be totally equal. So beta chain, and that will make hemoglobin A. There will be some gamma chain, and that will make hemoglobin F. And then we have delta chain, and that will make hemoglobin A2. So please note down, alpha chain on one height and all 3 chains have to be together, same height. So that means if for whatever reason beta chain is not made, say in beta thalassemia, this alpha chain cannot stay stable unless proportionately increase gamma or delta chain is made. So gamma and delta chain will be made in more concentration. ये उसकी numbers आ गए. This is detected by a test called hemoglobin electrophoresis. These 3 hemoglobins, they have different patterns of movement on electrophoretic patch. So on the first we have HbF, and then we have Hb2, and then we have Hba. So this is the pattern which we see normally. Their heights represent their normal concentration. Okay, so this you must be used to. You could see that these numbers, many laboratories report as percentage of hemoglobin A, hemoglobin A2, and hemoglobin F, and many also show this graph. So this is the normal. Please print this in your mind, and I'm going to show you the what happens in thalassemia, beta thalassemia. So in beta thalassemia, this beta chain is reduced. By definition, in thalassemia, there is quantitative defect. Beta chains are normal, but they are reduced in quantity. And so there will be reduced hemoglobin A. But there can't be any space here because proportionately gamma chain and delta chain will be increased in production to keep it balanced with alpha chain. So since gamma and delta are increased, so hemoglobin F and hemoglobin 2 will be increased. Hemoglobin A will be reduced and hemoglobin F and hemoglobin 2 will be reduced as shown here in the percentage. Hemoglobin A2 is increased, hemoglobin F is increased, and this graph will also change. Actually added some animation, but unfortunately their Microsoft 16, the older version, does not support my the latest. I work on Microsoft 365. So in nutshell, in beta thalassemia, alpha chain is normal, beta chain is reduced, but gamma and delta has to increase to keep it balanced with alpha. So hemoglobin A2 and hemoglobin F are increased. So that is determined by electrophoresis. That cannot be applied to alpha thalassemia, because in alpha thalassemia, alpha chain cannot be replaced by another chain. So all will be reduced, and that you will have to go to DNA analysis. So I think what I practice is hypochromic macrocytic anemia, rule out iron deficiency, then rule out beta thalassemia, then you are left with the diagnosis of alpha thalassemia without going for a DNA test, because other two important differentials you have already ruled out. Now we are still practicing. This is another case scenario. You have this CBC report. CBC report, first step, HB is reduced, hematocrit is reduced, both has to be reduced. So this is a case of anemia. Second step, look at the MCV, it is actually increased as compared to normal. MCV is increased, so we'll call it macrocytic. MCH is normal because these cells are pale, but they are actually bigger. This is macrocytic anemia. And in macrocytic anemia, we have 2-3 important differential diagnoses: vitamin B12 deficiency or folic acid deficiency. CBC picture will be the same in both conditions. You can't really differentiate between these two deficiencies on CBC. You will have to either go for the history will guide you, or you will have to do the assays. For example, folic acid deficiency develops in people who are taking anti-folate drugs. Many anti-epileptic, antidepressants, anti-neoplastic, anti-malarial, antibiotics, they are anti-folate drugs. So if somebody is taking anti-folate drugs, I'll suspect the folic acid deficiency. Somebody has chronic gastritis or has got additional neurological symptom, maybe I'll suspect vitamin B12 deficiency. So last case, this is another CBC. HB is low and hematocrit is low. So first step, patient has got anemia. In the second step, look at this. MCV is normal. 82, it falls within the normal range. MCH, again within the normal range. MCHC, again within the normal range. So what do you say? There is anemia, but red cell indices are within the normal range. So in this case, we will actually have to go to this panel because this could indicate bone marrow depression. A normocytic, normochromic anemia is more likely to be serious. Although from normocytic, normochromic, one might think this is more likely to be more normal, but it is actually more nasty thing. So it is more likely to be an aplastic anemia. Look at this report. TLC is less, platelets are also reduced, so it is pancytopenia. And if you see the relative ratio of polys and lymphos, it is reversed. It is reversed because polys are made only in the bone marrow, whereas lymphocytes are made elsewhere also. So when there is reduction in the bone marrow source, polys will be reduced much more than lymphocytes, so the ratio will be reversed. So this is, I think, a case of normochromic normocytic anemia and aplastic anemia. So this should make you, easy, although there is another possibility also. In most autoimmune, most hemolytic anemias are autoimmune, but there could be secondary hemolytic anemias also, secondary aplastic anemias. Okay. Now this is, coming to the end, this is how you go. First you see hemoglobin, hematocrit. If it is low, go to the CBC, decide which pattern patient has: hypochromic microcytic picture, macrocytic picture, normochromic normocytic picture. In hypochromic microcytic picture, iron deficiency, the diagnosis by default. If iron deficiency is unlikely, or you have some reason to suspect thalassemia, then you will go for the electrophoresis. Here you will go for the iron study. If it is macrocytic picture, you will consider vitamin B12 deficiency or folic acid deficiency. Both can be measured now on the laboratory test. And if it is normochromic normocytic picture, there would be possibility of aplastic anemia that you can very easily pick up from the CBC by altered lymphopolis ratio and reduce white cells and reduce platelets. And if it is hemolytic anemia, it would be mostly normocytic, but occasionally it could be slightly macrocytic also. So to summary, a careful inspection of CBC gives you valuable information to the likely cause of anemia. Combined with history and physical examination, further tests may not be needed in majority. So you can save resources, you can save money, you can save time. And next time you see this little perchy, please give it some more respect. Examine it carefully and it will give you wealth of information. All common anemias may be treated easily and diagnosed easily and treated easily also. This is my channel. I have many lectures, almost 3/4 of medicine is already covered. I am committed to cover it fully. This lecture is also available, and this is the QR code to my channel. Its name is Medistan. If you can remember this word, if you type Medistan anywhere on the internet, it will take you to my channel. Thank you very much.